there's been a lot of recent trials that have come out, specifically ARASENS, Piece 1, and ARANOTE. Let's talk a little bit about those trials. I guess I'll go back to you, Josh.
Yeah, sure.
With ARANOTE, what insights did you gain with ARANOTE?
I think we've talked about it already with the adverse effects. I think was the biggest thing. I think that just how well tolerated this medication is. These patients come in already on ADT therapy, miserable, hot flashes, night sweats, and to give them another medication on top of it that may make them worse it's a bit of a challenge to get them to buy into that. So to have a medication that you tell them you don't have to worry about interactions as much, you don't have to worry about the side effect profile as much. I think that's been the biggest benefit from what I saw when I read that trial.
Mm-hmm. Rene, what about you? What stands out to you about the ARANOTE trial that was recently released?
Yeah, tolerability. I think that's the number one. And like you say, all comers. You don't have to select one in particular, one group.
Mm-hmm.
So I think that's going to be even more important to be talking again about early intervention.
And significant RPFS change was big as well. So I think we're all kind of waiting for it to continue to evolve and get better data out of that, and be able to use it, without potentially using docetaxel.
Let's talk about docetaxel. We have the ARASENS trial that shows the benefit of triplet therapy. What's your, what stands out about the data from that trial as far as the true benefit?
Yeah, I think we talked about high volume disease. Those patients do better on triplet therapy. I just think you're paying a price for that, and do we really, is there some sort of synergy with docetaxel, with Daro that we really need or not? And I think we're all anxious to find that out. I personally think that, adding that potentially isn't making a big difference long term, but I think it is adding significant toxicity to these patients. And again, and part of it is because I used to give a lot of these guys docetaxel right up front, and I still have a lot of these guys who are still alive today doing great. What do they complain of? They're complaining about some of the permanent side effects from docetaxel. So again, I think we're all excited to see that potentially we can go to something that has better tolerability and potentially RPFS, OS, all that stuff's going to be great. Maybe be able to avoid that.
Mm-hmm. All right. Let's switch gears here now and talk about radioligand therapy. Radioligand therapy is one of the most exciting treatment modalities over the last couple of years that we've seen some impressive results with that. How are you currently including or integrating radioligand therapy into your practice?
So, we're blessed to, I know we're all early adopters, and we were sending some of our patients to one of the local hospitals to get lutetium right away, obviously with docetaxel because that was the approval. So we had to give that to that patient to get them that next step. In those guys that PSMAs have lit up, I've had some just tremendous responses from that. I think we're all looking forward to now that, again, docetaxel is no longer required for that. So I think, again, it's a relief for us because a lot of that toxicity, I believe, came from the docetaxel. I don't want to forget a couple other things that are out there, right? We all did immunotherapy. Can't forget about that. CYP-T, I think, is critical. The key now is where do you fit that in? Radium-223, again, we all used a lot of that. Sometimes, like I look at radium-223 and I look at CYP-T, and they've kind of gotten almost like overlooked, but both have great overall survival, and which is, again, critical, getting these patients to live longer. So again, I think the message is don't forget about all these things. Always be aggressively looking for when can I slot this patient into CYP-T, radium-223, and now, lutetium. And don't go maybe right to lutetium without looking at, did I give this patient immunotherapy with CYP-T? Did I give this patient, radium-223?
Yeah, I think it's interesting now with all these trials reading out is that early mCRPC, we have a lot of options.
Right.
Mm-hmm. And we have a lot of different modalities available. Like Ken outlined, we can go CYP-T, we can go radium, we can go lutetium, we can go chemo. Or clinical trial. How do you decide in that early mCRPC which one to use, or how do you sequence all these great therapies?
Yeah, that's a really good question. I mean, when I see a rapidly progressing PSA and metastasis, and especially in the patient who is symptomatic, I think I'm more aggressive to give, for example, lutetium, which I think would be a faster response. I don't know if that's true or not. I don't know if there's any trials comparing these things, but I like to think so. So if someone is symptomatic, that's probably where I go first. If someone is progressing, but there's no clinically any indication, yeah, we can go with immunotherapy, and then see how the response, and then adjust so there. I don't think I have a fixed algorithm on how to go about. I rely more on the clinical picture, how patient is doing. But I think if someone is symptomatic, is having symptomatic bone metastasis, SBRT for the area that they're hurting, that's possible, and then jump ahead with as aggressive as I can.
So, with you, Josh, what about with this early mCRPC?
Yeah.
Rene's treating based on symptoms. It will help determine which therapy to use. How do you decide what to go with?
Yeah, fortunately, being younger in the practice and in my career, I haven't really gained that many patients that have progressed onto that. But to Ken's point, a lot of the time is taking the clinical picture as a whole and trying not to forget about these other modalities that are available, CYP and radium-223. My experience with lutetium has been a patient who I inherited who had already undergone it, one of the first ones in Michigan, actually. And I'll tell you, his response was phenomenal. And not only phenomenal immediately, but has been durable over the last year to 2 years now. And it really, in these patients who have high volume disease that they really have, at this point there's no other option, it really offers them a guiding light to what could be available and hopefully continue on to remain, responsive and do well. So it kind of an all-encompassing clinical picture, I think, though, is really what it boils down to. And also offering the patient, to use them also in your clinical decision-making, that you offer up these different options and to them, which of these, appears to suit their needs best, too. Because a lot of the time, the different modalities do require a bit of a time commitment. And so I think that's also something to take into consideration also when you're making decisions with the patient.